everyone, and welcome to this evening's School of Hepatology webinar on the evolving management of viral hepatitis, advances in hepatitis B and Delta management. I'm Dr. Louisa Vine, I'm the BASL Education Co-Lead, and I'll be your chair for this evening, along with Victoria Snowden, who's also the BASL Education Co-Lead. I'd like to thank our sponsors for the evening, AstraZeneca, Novo Nordisk, Madrigal and Dr. Falk. I'd like to point out that they have no influence or input into the programme, agenda or content of the meeting. So next I'd like to introduce our speaker, Professor Patrick Kennedy. Professor Kennedy is a consultant hepatologist at Barts Health NHS Trust. His work in viral liver disease is known internationally and he's well published in the field. He's produced novel work redefining disease phase in hepatitis B virus and investigating the role of individualised treatment and management strategies for chronic hepatitis B patients. Professor Kennedy is a member of the Viral Hepatitis Clinical Guideline Committee for NICE and provides expert opinion for the United Kingdom Advisory Panel on Bloodborne Viruses. So it's a great honour to have him speak for us this evening. If you have any questions, please put them in the question and answer section and we'll go through them at the end of the talk. But Patrick, thank you very much indeed for your time and we look forward to your talk.
Thanks, Louisa. It's a real pleasure to be here. So there we go. Good. So good evening, everybody, and thank you for joining the webinar this evening. I'm sure lots of you have got better things to do with it being just a couple of weeks away from Christmas. So anyway, I'm going to take you through what are the latest advances in chronic hepatitis B and Delta virus. So I'm going to kick off by just reminding all of you about the various types of viral liver disease that you'll all be very familiar with. Of course, we're not focusing on hepatitis A or hepatitis E virus this evening, as these are acute self-limiting viruses. And in terms of advances in the management of viral liver disease, I think most of you will also be very familiar that hepatitis C is not really an issue in terms of management anymore because we can achieve cure with the direct-acting antiviral agents that we have at our disposal. And hepatitis C is really moving into the territory of ideally out of secondary care hospitals and into primary care, or at least shared care across secondary and primary care moving into the future. So really the challenges in chronic hepatitis B revolve around those with chronic hepatitis B and delta hepatitis or HDV. And I'm going to talk through specifically through the various challenges and the progress that we've made over the last few years, and then bring you right up to date with some of the most recent publications in the field. What I'm going to do to try and make it interesting for you, I'm going to give you some of the kind of scientific background of driving some of these changes. Hopefully that will be of interest. And then we can come and deal with any of the questions that you might have in the question and answer session later on. So I'm going to start by reminding all of you that hepatitis B is an oncogenic virus. And the fact that it's an oncogenic virus actually is what makes it so challenging, but also similarly so interesting. Remember, hepatitis B is a DNA virus that integrates into the host genome. So once you have it, you actually never really get rid of it. And you'll all be familiar with this in the context of HBV reactivation in patients being exposed to immunosuppression, and particularly with B-cell depleting agents like rituximab. But just to give you an idea, this is one of the seminal papers which really highlighted to us that the level of HBV DNA, so that's the level of replicating virus that you test in the blood. If you look on the right side of this slide here, the higher this is, the higher your chance of developing liver cancer or the higher chance of developing chronic liver disease or cirrhosis. And of course, this is the seminal REVEAL data. Many of you will have heard about this, almost 20 years old now. This study is not ideal in terms of its design for many reasons, which I'm not going to go into this evening, but suffice to say that it gave us a very clear indication that the higher levels of virus, the more likely you are likely to come to harm from chronic hepatitis B. Then I'm going to move on to this publication that I led for the international collaboration on the elimination of hepatitis B. And this was a paper that we published in Lancet Gastroenterology earlier this year. And it's a paper which I think is worth looking at because there's a sister paper on the public health challenges of chronic hepatitis B. So this is the kind of medical and scientific element, but there's also a sister paper on the public health challenges. So together they're two good papers, which I would consider two good reference points. But if, as a physician who treats chronic hepatitis B, you're like me and you want to know what are the challenges with chronic hepatitis B, well, look at the left-hand side of this figure. 254 million people living with chronic hepatitis B globally. Now move across to this right green shaded area, and that shows you that we only have 6.6 million people actually on antiviral therapy. So that's less than 3% of patients that we believe have chronic hepatitis B globally are actually having antiviral therapy. Now, there's a lot of reasons for this, and if you look at the cascade of care that I'm showing you here, why patients may fall out of this kind of management. But clearly one of the key elements over the last, I would say, 5-10 years that we recognize as being a barrier to people accessing treatment is the complexity of chronic hepatitis B, and certainly the complexity around the management of chronic hepatitis B. So that's quite important, and I'm going to talk about this a little bit more as we move forward. On the top right of this slide, I want to highlight something new, another publication in the Lancet. And what this paper does, which is a really important paper for me, it took the number of liver cancers complicating chronic hepatitis B around the 2015-2016 time frame, and then projected the number of liver cancers that we would develop from chronic hepatitis B in around 2040. And based on this paper and based on this analysis, it's predicted that we will see doubling of the number of liver cancers from chronic hepatitis B globally by 2040. Now, why do I think that's important? I think that's important because this is 2025, which means that we actually have 15 years before we see that peak in the number of liver cancers from chronic hepatitis B. Remember, it's an oncogenic virus. And that means we've only got 15 years where we can make some impact or inroads into the management of our patients with chronic hepatitis B. And why is this 2040 timeframe important? Well, there's lots of data, probably most well-known data is from the Polaris Institute led by Homi Razavi, which says that between 2040 and 2045, there'll be a peak in the number of liver cancers and chronic hepatitis B globally. And after that, they will start to decline rapidly because vaccination programs begin to kick in at a demographic level at that stage. So that's just to give you some insight around that. These, of course, are the classical disease phases of chronic hepatitis B. And why I show you them is if you look at phase 2 here, just second from the left, and phase 4 on the right, these are the phases where we see perturbation in the liver enzymes, so abnormal liver enzymes, fluctuation in HBV DNA. And these are the phases of the virus that we refer to as the hepatitis phase of the virus in the EASL guidelines. So you've got E antigen positive chronic hepatitis and E antigen negative chronic hepatitis. But what I'm showing you these here is because up until now, we only treated these two phases of the disease. And that's pretty odd kind of approach to the management of a chronic viral infection. You might agree with me on that. I certainly think that is the case. And it's very different to what we see, for example, in the HIV field. Why was that? Well, these classical disease phases go back for years, probably back to the 70s. And, that was the teaching, that was the understanding, this concept of immune tolerance shown here on the left column, immune active, immune control, immune escape, going across from left to right. But some of these concepts don't really stand up to scrutiny. I'm going to show you a little bit about that. But also at the bottom of these columns, or at the bottom of these phases, I'm showing you how we better understand these phases based around virological markers, cccDNA, correlated antigen, serum HBV RNA, and the large element of surface antigen. So our understanding of chronic hepatitis B has changed dramatically in recent years, and it's for this reason that we're seeing changes or advances in how we approach the management of chronic hepatitis B. So I started off by saying chronic hepatitis B is an oncogenic virus. It's a virus that if we don't do anything, we are exposing our patients potentially to the development of liver cancer as a complication. Now, if you crudely look at host factors and viral factors which are associated with the development of liver cancer in untreated chronic hepatitis B patients, let's start first of all with the host factors on the left. Okay, your gender, your family history, and where you're born, there's very little you can do about this. But we know that individuals tend to develop cancer most commonly from about the fifth decade. So, obvious question here would be, why do we wait so long, or why do we delay before we treat patients with chronic hepatitis B? Now look on the viral and disease factors. So again, cirrhosis, high level of HBV DNA greater than 2000, elevated ALT. This to me is a failure of management. Anybody with cirrhosis shouldn't have cirrhosis if they were treated. High HBV DNA, why are we not treating these patients? Elevated ALT reflecting ongoing liver inflammation, we should be treating those patients. But there's only two non-modifiable factors here. That's the genotype of the virus and the time frame to e-antigen seroconversion. We're not clear exactly what the drivers of this are. Are these host elements that we're not sure about, or are they also related possibly to the genotype? But these are unresolved questions. But again, suffice to say, you can see there are a number of modifiable factors on the viral and disease side that we should be able to avert by managing these in a more prompt way. Now, if you know anything, or if you've been reading about chronic hepatitis B in the probably, I'd say, for about the last 5 to 10 years, an area where there's been a lot of research, a lot of interest, and a lot of focus is around the concept of HBV integration. And this is another simple cartoon highlighting to you the various strategies for the development of liver cancer and chronic hepatitis B. So take the top line here, increased cccDNA, pregenomic RNA. This is the viral reservoir, driving inflammation, driving fibrosis, cirrhosis, liver cancer. That's a common paradigm that you'll see in all chronic liver disease, with fibrosis, the scarred liver, going on to leave you with the development of liver cancer. But in hepatitis B, as it's a DNA virus and integrates, you also have a direct mechanism of hepatic carcinogenesis. That's the integration of the DNA virus into the host. And that in its own right is a driver of liver cancer. So in chronic hepatitis B, essentially you have two drivers which are directing or pushing susceptible individuals to the development of liver cancer. So what is the rationale for early treatment in chronic hepatitis B? And I put this here as a question for you because I want you to think about patients that you see in the clinic, and think about patients that you're considering whether you should start antiviral therapy or not. And I'm trying to make that easy for you by showing you that hepatitis B is an oncogenic virus. And in my mind, you should have a very good reason why you're not offering that patient antiviral therapy. And there are some, and we'll come back to those as we go on. But essentially, the reason for early treatment is to mitigate the risk of liver cancer. Because, and we'll talk a little bit more about nukes as we go forward and what they can do, but we will come back to that. So I want to start, I said I would put some kind of scientific data in here just to kind of give you some grounding, or to anchor all of this for you. There's a series of papers that we published at QM in gastroenterology, all on this same theme, which actually have been some of the key papers and drivers of changes in how we manage chronic hepatitis B. This is the first one of those papers, which was published in 2012 by myself. And what we did was a very simple experiment. We looked at young people in my clinic. These were people as young as 15 in a transition clinic. And we looked at those people who were described as immune tolerant, immune active, and we looked at healthy controls. And then we studied the kind of immunological elements of these individuals to better understand, well, were they really immunologically tolerant or not? And what I'm just showing you here is a very simple marker, PD-1 positive CD8 T cells. And we're looking at the percentage of these in the periphery. So relatively easy experiments to do. But what I want to highlight to you here is that when we looked for evidence of tolerance, comparing immune tolerant from the age-matched immune active patients, we saw no difference in that immunological profile. So the people who were labeled immune tolerant weren't actually immune tolerant at all. And I can show you that very simply by showing you how the healthy control bloods look like, how this compares. And you can see these, statistical differences which are the same between those who are described as e-antigen positive chronic infection, e-antigen positive chronic, from those with healthy controls. If those immune tolerant patients are actually tolerant, they should be like the healthy control patients, but they're not. And then another very simple observation was that we were able to study more patients in my clinic. And as these patients aged, And as they went into their fourth, fifth, sixth decade, as I'm showing you here on the right, their T cells became more exhausted. So what does that tell us? That tells us that, well, if you're trying to achieve cure and you're reserving treatments to very late or novel treatments to very late, you're going to find it more difficult to achieve this because as patients are older, above the age of 30, 40, 50, their T cells are becoming more dysfunctional, and your ability to be able to reverse that dysfunction to a functional immune response is obviously diminished. Then we went on to publish a paper in Gastroenterology in 2016. And this is really an important paper because this is where we really highlighted the development of this clonal hepatocyte expansion and HBV DNA integration. And I'll show you here, this is the study of liver tissue in these individuals in the clinic. And I'll just draw your attention to the top left again. And if you see in that top left, you'll see patients as young as 15, 17, 18, where we biopsy them and then we study the development of clones and integration. And we're saying that this is virtually no different to those who've got e-antigen positive immune active disease. Notably, the clones get bigger as you move through the phases of the disease. That's probably because we're not doing anything. And then the maximal clone sizes are seen down here in those patients who develop HCC. So clonal hepatocyte expansion, a clear risk factor for the development of liver cancer. And I'm showing you here in the middle figure, what I'm showing you there is that this is clonal hepatocyte expansion, turnover of hepatocytes above what we would expect as natural turnover in an individual. So very simple observations, but important observations highlighting the mechanisms of hepatic carcinogenesis and chronic hepatitis B that are present, by the way, in teenagers or people in the second decade of their lives. Picking up on this theme around age-related immune changes, we study this, and this is a paper we published, Antonio Bertoletti, in Gastroenterology in 2020. And what's interesting about this is, if you look at the donut plots at the bottom, starting on the left, what I want to show you here is that the envelope-specific response, so one of your lines of defenses, one of the, there's the core specific response, the polymerase specific response, and the envelope specific response, or the S specific response. Now, what I want to show you here is if you look at these donut plots and you look at the ages above them, as you move from left to right, first two decades, second, third decade, now you're into the third, fourth decade, you can see these orange plots are disappearing. This is the disappearance of the envelope-specific response. So one of your lines of defense against chronic hepatitis B is basically vanishing as you get older, and that fits exactly what I'm saying to you from the previous slide, that your host immune response becomes more dysfunctional as you age. And not only does it become more dysfunctional, but we think you actually lose some of the virus-specific response and specifically the envelope-specific response. And, this was studying a huge number of patients, almost 250 patients with very detailed analysis using ELISpot, CyTOF. So this is a comprehensive assessment of both global T cell and NK cell immunity in people living with chronic hepatitis B. In 2020, which this paper was, we also published this paper in Gut. And what's interesting about this, and what I want to highlight to you here is, while we associate integration and the most integration events being in those individuals with very high levels of virus, e-antigen positive chronic hepatitis B, who haven't been treated, so very high levels of viremia, lots of integration, lots of viral activity if you want. But now look at those people that you will see in your clinic here, less than 2,000 IU per ml, between 2 and 20,000 and greater than 20,000. And what I'm showing you here is a heat map about the differentiated expressed genes in the relation to HBV DNA integration. And very simple take home here is we were able to identify integration events also happening in those individuals with very low levels of virus, where there's low levels of cccDNA, low levels of transcriptional activity. So where the virus may be contained at a kind of virological reservoir level, there's integration already there and continuing. And remember then putting those individuals potentially at risk for the development of liver cancer. So very, important observations in terms of signposting where we may go in terms of treatment of chronic hepatitis B. And then these are data produced by colleagues of mine and friends in South Korea. There's two papers. There's a previous paper to this where they showed very clearly that when you took immune tolerant patients, compared them with immune active patients, And the immune tolerant patients, of course, weren't treated. The immune active patients were treated based on their ALT levels, but the immune tolerant patients had a higher rate of liver events, transplantation, death, liver cancer, because they weren't treated versus the immune active patients who were treated. So a very clear, I would say, development of the data that we'd shown to say, well, there is risk in those highly viremic patients who are not being treated. We were able to show that at a basic science, at a, at the very kind of cutting edge of looking at the kind of host immune response. They were able to show it in terms of a clinical trial, in terms of patients who were and weren't treated. And then you look at this concept, which they published more recently, this nonlinear association with HBV and HCC. Now, this is really interesting to me because if you look at this and you look here at the x-axis where I'm showing you the arrow is, what that's showing you is the virus is reducing, this is without any treatment, from 7, 8, 9 logs that we see in you very young people, as it moves down on that scale down to about 6 logs. This is where the HCC risk seems to be greatest. We think this is because there's continuous host immune activity against the virus for whatever period of time that it takes you to get from 9, 10 log, which is what the liver is capable in terms of replication capacity, down to this 6 log. So while you're sat in the clinic looking at patients with 7 log with kind of normal levels of going, this is all fine, there's not much going on. Actually, there is something going on. And what's going on are those hepatocarcinogenesis mechanisms that I talked about in some of my earlier slides. So, in a nutshell, I've shown you a lot of very fast run through kind of scientific data, research that we've undertaken, research other people have undertaken to show you, well, the kind of status quo of what we were doing in chronic hepatitis B isn't going to stand up. So we need to consider how we're going to change things. And this is where I'm saying how this research can impact clinical practice, and not only impact clinical practice, but how can we move forward? How can we move towards functional cure, which is what we're trying to achieve. So you will probably all be familiar that in the last couple of years, there's been a lot of changes in the guidelines. The WHO guidelines 2024, I was part of the guideline development group for this. The Chinese guidelines, which preceded this, date back to 2023. And these are pretty comprehensive sets of guidelines, and you will see even at a glance of these, and you'll have these slides after my presentation, but there's a clear direction of travel here, and that direction of travel is lowering the threshold to offer antiviral therapy. And that brings me to 2025, the publication of the EASL guidelines at the European Liver Meeting this year in Holland. And you'll see myself, lots of us from around Europe, worked on this for about 18 months. And to me, the EASL guidelines are probably the most comprehensive guideline for chronic hepatitis B. So as a reference point, this is a fantastic place to go to, more so than WHO and more so than the Chinese guidelines. And maybe we'll come back to that in some of the questions. But I'm going to make it very simple for you, because this was the EASL statement, which started with the idea that all surface antigen positive individuals with detectable HBV DNA are candidates for antiviral therapy. And the reason for this is that we are saying that treatment in this case, although based primarily on HBV DNA, ALT levels, biochemistry, fibrosis stage, risk of liver disease progression, liver cancer, at the end of the day, the new guidelines recognized a shared decision-making process. So that is the physician, the individual living with hepatitis B, deciding together what is in that individual's best interest. It's not that you cannot have treatment because your viral load is this, or you cannot have treatment because your ALT is normal, or you cannot have treatment because your FibroScan was whatever it was. This is trying to move the field forward to ensure that people can see that we are being progressive and we are offering individuals treatment so they benefit from treatment, and we have an impact on the course of chronic hepatitis B, most obviously for the reasons I was talking earlier, the development of liver cancer. Now, this is the simplified treatment algorithm. I'm not going to go through this with you because you can look at these slides later and see it. But what I just want to highlight to you is that if you look at advanced fibrosis here, I'm just going to highlight this for you. Advanced fibrosis or cirrhosis. What is advanced fibrosis? Advanced fibrosis is a FibroScan score of greater than 8. So you got a FibroScan greater than 8, you've got detectable HBV DNA, you can have treatment. Look down here, HBV DNA greater than 2000, yes. ALT above the upper limit of normal, fibrosis, risk factors. So look at the fibrosis here in 3. This is a median liver stiffness of greater than 7. When your HBV DNA is greater than 2000, you can offer this individual treatment. So what I just want to highlight to you here, without going through each of those single boxes, is that the barriers to treatment have been removed. In my practice, if somebody's got a DNA of over 2000, they're above the age of 30, I offer them antiviral therapy. If you are being more, how will I say, following, some of the more historic interpretations of chronic hepatitis B, you might go, oh no, that's too liberal, that's too hawkish in terms of access to treatment. But I think we need to think more about the patients and the benefits and what they'll get. And this is why, in my practice, certainly, I really lower the bar in terms of offering people antiviral therapy. I wanted then to move forward because I'm sure we'll come back to the discussion about how we're approaching treatment and what we're doing in the clinic. But you'll also want to know about the functional cure program. How close are we moving to this? Well, there's a drug. It's this drug from GSK. It's an antisense oligonucleotide. And these are essentially the next generations of drugs in viral liver disease and other diseases for that matter. But this was published in the New England Journal of Medicine just a couple of years ago. And what this is bepirovirsen, which is the GSK antisense oligonucleotide, shortened to Bepi. And this drug will be in the clinic we think, in the Far East in 2026. So where will we be in the UK, in Europe, in terms of access to this drug? Many of you may have come across this drug in many of the GSK clinical trials, but this drug we expect to be in the clinic in 2026, probably in Japan and the Far East as of next year. And we'll talk a little bit more about that because I do think the antisense oligonucleotides are an important drug as we move towards functional cure. Just a couple of months ago, just before ASL, we published this clinical trial in gut. This is the REEF-IT study, first started, by the way, before the pandemic. Just shows you what the pandemic did to clinical trials and everything. But this is a really key paper for me. It picked up on our work around the treatment of younger people, the treatment of people with e antigen positive chronic hepatitis B. So this is exclusively a clinical trial using an siRNA in those individuals with e antigen positive chronic B, high viremia, never previously treated. And what we showed was that when we treated them with the siRNA, we made good progress in terms of reduction in surface antigen. Then they had a 12-week addition of pegylated interferon. They had much more dramatic reductions in surface antigen. That's just 12 weeks of an immunomodulator. And in this cohort of previously considered very difficult to treat people, surface antigen loss was observed in 20% of those individuals, 1 in 5, with a maintenance of surface antigen loss of 11% out to the end of study. Now, these are important data not because they're demonstrating cure and you're going to be using these drugs in the clinic in the next year or so, but these are important data because they're providing the kind of roadmap as to how we might use these drugs and how we might use them in combination as we move forward. So this is a very important study on the back of the antisense oligonucleotide. And just so you're aware, GSK have since bought this drug from Janssen, this siRNA, and a combination of this siRNA and antisense oligonucleotide is currently undergoing clinical trials. And this is another paper of ours, and I wanted just to put this in. I'm not going to dwell too much on this, but what I wanted just to highlight to you is if you look at treatment discontinuation with nukes, etc., well, the lessons that we learn from treatment discontinuation with nukes can move across into the functional cure sphere. And what we're seeing here are some of the changes, some of the thresholds, some of the parameters which tell us virologically around you need this to achieve functional cure, but also combining this with these immunological readouts, which are equally important to signpost or to determine whether functional cure will be achieved and whether it will be durable or surface antigen loss will be durable. So what are the challenges in future research? Well, in chronic hepatitis B, 254 million people globally with chronic hepatitis B, about 6 million people on treatment. The biggest challenge is upscaling diagnosis and access to treatment. That's, you don't need to be a physician or a public health specialist to recognize that. HBV integration in chronic hepatitis B is the single biggest barrier to functional cure. Does it matter? Does it matter that we're not able to achieve surface antigen loss? Remember, the integrated DNA continues to produce surface antigen, but we're seeing some situations where we're able to achieve surface antigen loss functional cure. So let's keep that kind of open for discussion as we move forward. What about combination of these new drugs? You're all used to using nukes, tenofovir, tenofovir. 98% of our patients are on those in the clinic. We are talking about a whole new class of drugs, siRNAs, antisense oligonucleotides, the combination of these drugs, other immunomodulators, other direct-acting antiviral agents like CAMs. Studies for these are ongoing. What about the mode of action of nukes to reduce integration of clonal hepatocyte expansion? Remember, you know that clonal hepatocyte expansion and integration is an area where we associate with hepatic carcinogenesis, but we don't quite know what nukes are able to do there. But what we do know is nukes can suppress virus, normalize ALT, and even reverse fibrosis. It's possible they may even be able to do more than that. And then how or what studies do we need to do to harness the host immune response to achieve these treatment outcomes and achieve functional cure? So now I'm moving on to delta hepatitis. And this part of the study, or this part of the talk, is going to be relatively short, if you can hear me above my dog barking in the background. But what I want to start by highlighting is, first of all, you need to think about delta hepatitis when you see these people in the clinic, because if you don't test for delta antibody, you're never going to know whether this individual has delta hepatitis. So, this is why we have put so much focus on reflex testing, where anybody who's surface antigen positive should have a reflex test for delta antibody. And then the delta antibody is positive, they're reflex tested for delta RNA. Delta RNA is positive, so HTV RNA is positive. We should be treating those individuals for delta hepatitis. And that's very simple, it's an uncomplicated message to follow. Now, why is delta hepatitis so important? Well, just look at this. On the bottom here, I'm showing you how delta hepatitis is the most aggressive form of hepatitis. We think you've got 2 to 3 times higher chance of development of cirrhosis compared to HBV monoinfection. We've got 3 to 6 times more chance of development of liver cancer compared to monoinfection. And here we see again about 2 times greater chance of decompensation, liver transplantation, or mortality with delta hepatitis compared to HBV monoinfection. What about treatments? Well, you'll all have heard of bulevirtide, or I hope so, because bulevirtide is available in the clinic and we are currently using it. This is the New England Journal of Medicine paper published last year. Now, what's interesting about this paper, you will see, it looks at the combination of bulevirtide with pegylated interferon, but Gilead's license and our ability to use bulevirtide in the UK is not in combination with pegylated interferon. So this is one stumbling block. The other stumbling block, for those of you with eagle eyes here, you will see that this is bulevirtide 10 milligrams that Gilead is pursuing and will probably getting license for in the US. But the dose in the UK is 2 milligrams bulevirtide administered daily. And that is at present, that's a continuous lifelong, if you want, treatment at this point, at least. Now, I want to shift gear a little bit and show you data presented at ASL this year. And this is a phase 2 study that we were involved in. This is called the SOLSA study, and it's from Vir. It's a combination of an siRNA and monoclonal antibody. So the siRNA is elebsiran and the monoclonal antibody is tobevibart. And you'll see down here, there's 65 patients randomized to the monoclonal antibody or the combination of monoclonal antibody and siRNA. I talked earlier about this next class of drugs in viral liver disease. Now you're going to see how important these drugs are. Just quick glance at the right-hand side there. You'll see these patients are all very similar, about 50% of patients with cirrhosis, by the way, on entry into the study. So have a look. This is antiviral responses, combination therapy, the monoclonal antibody. So combination clearly superior. But let me draw your attention here to this concept of HTV RNA target not detected. We are not able to detect any virus in the blood at 48 weeks, and we achieve this in 66%. That's two-thirds of individuals achieving the combination versus 50% achieving the monoclonal antibody. Draw your attention quickly, pretty good normalization of liver enzymes. You'll all be familiar, delta hepatitis patients, very marked, aggressive forms of viral hepatitis. So we're seeing similar levels of normalization of the liver enzymes, which is important. But this is only week 48 data. So the data looks good. Now, moving quickly onwards, now I want to show you where these drugs really differ. This is in terms of reduction of surface antigen. So if you look at the combination approach here, this is the siRNA with the monoclonal antibody, we're achieving minus 3.6 log IU of surface antigen. And if I show you over here with the combination, we're achieving about 90% of individuals on these drugs with a surface antigen titer of less than 10 IU. This is really pretty impressive. And I can tell you that the data, which you're going to see more of probably at EASL, is that as these individuals remain on the drug for longer, they become more target not detected. And we think more target not detected, lower levels of surface antigen. This is probably really shifting the field forward in delta hepatitis and possibly even to a finite course of treatment. So this led to this New England Journal paper just published a month ago, published actually at the time of ASL when we were in Washington. And this is a good paper for you to refer to understand where the field is going to in terms of the treatment of delta hepatitis. And I think this is the most impressive data that I probably saw for viral liver disease at ASL. So that leaves me just with the kind of tying up with the take-home messages. So for all of you, you've joined this evening and you could be out celebrating, at a Christmas party or something. So I think the big take-home is the field of viral liver disease is moving at pace. I've just shown you the huge progress that we've seen in delta hepatitis. Remember, this a couple of years ago was the most severe form of viral liver disease. Young men, cirrhosis, decompensation, liver cancer, 30s, 40s, really aggressive disease. We now have really good treatments for the management of this. I think a major focus of all of ours, and that is across the specialty, that is within secondary care, tertiary care, into the community. We need to have more awareness, diagnose more people, treat more people with hepatitis B and delta hepatitis, as I've just shown you. I think in chronic hepatitis B, I think it's really interesting because we have highly effective drugs, extremely safe, affordable, but we don't use them enough, and we're not prescribing them enough to enough patients, in my mind, that is. And we are also now beginning to see that nukes, beyond what I said to you, viral suppression, normalization of liver enzymes, reversal of fibrosis, cirrhosis, they may also be having an impact on integration and clonal hepatocyte expansion, which is very interesting for such simple drugs. So again, it begs the question, why are we not using these drugs more? And that's certainly my practice. I'm a real advocate of treating more people. And then finally, expanding access to treatment in chronic hepatitis B, treating more people. This will reduce the complications of chronic hepatitis B, obviously, and the development of liver cancer. In my opinion, if people were put on an antiviral at a young enough age, maintained on that, they'd probably never get liver cancer, because even the nukes are at that point probably impacting that direct mechanism of hepatic carcinogenesis, if you want. But again, big progress in chronic hepatitis B, big progress in delta in terms of those new therapies that you're seeing. And of course, you do have bulevirtide in the clinic for the appropriate patients based on the NICE approval. And then finally, I am going to close. This is the app which we have developed at QMUL. Almu, who is my fellow here, is working on this and working on its dissemination. This is an app for people both living with chronic hepatitis B, but also healthcare practitioners managing it. Please feel free to download it. It's free, use it. And hopefully we can help people who are living with chronic hepatitis B and people managing it. So, this burden and volumes and numbers of patients becomes less of an issue for us because we've got these tools at our disposal to use. So thank you for your attention. It's been a real pleasure, and it's good to have everybody here, and I'm happy to take questions. Thank you. Thank you.
Great. Thank you very much for an excellent talk, Patrick. I'll kick off the questions. Firstly, I mean, obviously you showed that slide with the number of people we assume are living with chronic hepatitis B and the number who we actually know about and that kind of onwards. What are your views on how we can improve detection then, particularly in Britain?
Oh, I mean, Vicky, that's a really good question. I think, there are some initiatives certainly around, for example, the ED testing. And, we've been, trialing that in London for a long time. And, what we've seen is we're seeing three, four, five times the number of new diagnoses of chronic hepatitis B compared to HCV or HIV. So this is just kind of scratching the surface that when you start to look, you're finding many more individuals with chronic hepatitis B. So we need to build on that. We need more awareness. We need probably primary care testing more. But all of this, I think, really relates to, education, information, dissemination of what we know, and then trying to find, diagnose, and offer people treatment.
Great, thank you. And I'll kick off with the questions from the attendees. So the first one, it says, anonymous attendee, in a decompensated cirrhosis, are you still using entecavir 1 milligram daily?
Well, first thing to say, we don't see an awful lot of decompensated chronic hepatitis B cirrhosis that we need to use entecavir 1 milligram daily. No, I mean historical data showed that, but in my practice, I don't think it's a huge deal. Um, of course, it would depend on the virological status of that individual. Is there detectable viremia? Is there a suggestion potentially of resistant mutations? That might change what you do there and what drug you would use. But yeah, that historical data has been around for a while. In some circumstances, the answer would be yes, but I would be probably more circumspect about how I would approach that individual in their treatment. Yeah.
Great, thank you, Patrick. A really great talk. So there's quite a few questions that are coming through on the Q&A. So I'm going to go with some of those if that's okay. So one of the other ones we've got, they're basically saying, so you would treat almost every patient with hepatitis B if they had a detectable hepatitis B virus and they're over the age of 30. So they just wanted to clarify.
Well, actually, that is you've whoever that was just summarized the Chinese guidelines there because the Chinese guidelines say exactly that, that if you're over the age of 30 with a detectable level of HBV DNA, you're offered antiviral therapy. There are 100 million people with chronic hepatitis B in China, so they have to be aggressive about how they approach it for obvious reasons. I'm more of the school of thought that if you have, and I'm going to kind of approach this question the best way I can, that if you have a viral load above 2000 IU and you're over the age of 30, I have a conversation with every individual about starting antiviral therapy in that instance, irrespective of the FibroScan or the ALT. If you have a viral load above 2000 IU, above the age of 30, there's a good chance you will probably have a FibroScan above 7, like I just showed you on the EASL guidelines. And the ALT has to be abnormal, but there's no threshold provided for what that abnormal ALT is. So you can determine what level is an abnormal ALT to you. But what's interesting, the flip side of that question is this, that there is a cohort of people living with chronic hepatitis B who have low levels of HBV DNA, normal liver enzymes, and normal FibroScans. And usually, historically, they were referred to as, people call them asymptomatic carriers, inactive chronic hepatitis B, all of these kind of terms that have been used over the years. Interestingly, these individuals have a very contained reservoir of the virus in their liver. So they probably have transcriptionally inactive cccDNA. So we think they are the safest people that have chronic hepatitis B who do not come to harm. So the answer to the question really is you have to be able to understand that individual's disease phase and what you are dealing with. And if they are genuinely a patient who's over the age of 30 with low level of virus, with normal FibroScan, with normal ALT, these are the individuals who are probably very safe and do not come to harm over a long period of time. So, I could offer them treatment, but I'm not really changing the course of the disease. But if that individual said to me, "Oh, my DNA is 980, I'm not happy not being treated," I would say, "Fine, we'll treat you." Because at the end of the day, this is the concept of shared decision making between the physician and the individual.
Thank you.
I hope that answers the question.
I mean, I think there are two more on the same sort of tack as that. So, sort of asking about what about patients in their 20s with high viral loads and normal ALTs?
So the patients with high viral loads in their 20s and normal LTs, I've just showed you the data from the REFIT study, just published in Gut. People can look at it if they want to. Um, these individuals actually seem to do very well when we treat them with these new therapies like siRNAs. So again, if somebody's in their 20s with a viral load of 8 log and normal ALTs, I will have a conversation with them and say, if you want to have treatment in this scenario, you can have treatment with an antiviral agent, tenofovir most likely, to suppress the virus, to get you to the closest place that we consider you're safe. We're turning off the virus, we're suppressing it, we're probably turning off integration events as well with that. But you have to accept that you're not going to achieve cure just with an antiviral, just administering like this in this type of scenario. But I don't think these individuals lose out in this way. I think that if they are virally suppressed, they'll be offered a newer therapy, an add-on therapy, access to a clinical trial in the next couple of years or so. Um, my ideal scenario for those individuals there would be that they're accessing the next generation of drugs that I just talked about, siRNA, where they did very well and did very well with just 12 weeks of interferon on the back of it. I would like to see, the data kind of emerge and maybe more mature data where these people are going to get access to an siRNA and maybe an antisense oligonucleotide in combination or in sequence. That's the direction of travel for these people in the future. But for now, if you're worried, if the individual's worried, absolutely, they start an antiviral.
Right, thank you.
Great, thank you. So I think there's another question that came through about HCC surveillance in hepatitis B, and that's one of the questions I wanted to ask you about, like who are you surveying? But one of the questions from the attendants was, would you use any HCC risk scoring, so such as the AMAP score in routine practice?
I mean, in routine practice, we use Page B, we use REACH and the modified REACH scores. I mean, look, if you look at EASL, there are different kind of sources for HCC surveillance. There's the HCC surveillance document itself, and then there is all the kind of viral liver disease documents or the hepatitis B guideline. And, we tried not to be overly prescriptive there, but, in the clinic, certainly in a Western clinic, Page B is very good. And if you are, historically, if you meet criteria for antiviral therapy, you automatically met criteria for surveillance. I think we probably need to be a little bit more selective as we move forward. And, especially with starting treatment earlier and how we go back and revise and look at HCC risk in terms of surveillance moving forward. But at this point, it's a safety first approach in my mind.
Great, thank you. The next question is, I think one of the attendees said, could you just recap what first line for treating hepatitis B and Delta currently?
In the UK now, people will have access to bulevirtide if they have evidence of advanced fibrosis, cirrhosis, but do not have decompensation and are intolerant of or have failed pegylated interferon. So any patient that you have in the clinic with delta viremia, you should be thinking about this individual accessing bulevirtide. We are not using it for decompensated delta hepatitis patients, although there is anecdotal data and we've used it in certain cases, but that's not the license for it in the UK. So you have a delta RNA positive patient in your clinic. The discussion you should be having is, can I access bulevirtide for this individual, which is a 2 milligram daily dose. Yeah.
Thank you.
Great, thank you. So we've got a couple more questions coming through about treatment. So one of them is, would you start entecavir or tenofovir first? And then another one is, what would you prefer to use on young patients in an immune tolerant state? So what's your
Well, probably taking the last one first. I mean, to avoid complexity, if you have people in their, let's say in the third decade, 20s, whatever, and you think about antiviral therapy, if it's a female patient, it's going to be tenofovir, maybe just to make things easier for that person who's overseeing the management there is you might just use tenofovir across all those young people. So you just start, that could be a practice. In terms of actual viral suppression and kind of getting those individuals to a level of viral suppression, there's not really much in it in terms of differentiation between those antivirals. There's a hint of data around HCC development, differentiating in those antivirals. It's not very robust data, so I would maybe steer away from that. But for young people, just because of the issues around pregnancy, I would probably say tenofovir is just easier. By the way, there also seems to be continuous issues with access to entecavir for some reason. It has something to do since we had Brexit. So I think tenofovir is also easier to source.
Thank you. So there's a question here about post-transplantation for hepatitis B. So the question is there a significant risk of developing further liver disease, so cirrhosis or HCC, post-transplant, despite being on antiviral therapy? And how often would you monitor the HBV DNA levels?
No, I mean the short answer to that is no. I mean, but between the combination of hepatitis B immunoglobulin and antiviral therapy, I mean, there should be no issues with hepatitis and with hepatitis B driving liver disease in that scenario. Just don't see it.
Yeah.
Great, thank you. And we've got another quite challenging question now. How do you convince your young patients to be compliant with taking antiviral therapy daily for such a long time?
No, look, that's a good question. I mean, there are two elements to that question. The first thing is, I actually really believe this is about education. If you spend long enough with an individual and you explain these are the reasons why we're doing this, I think more often than not, they get it. Of course, you also have my app, which can remind you about taking antiviral therapy. So that's also very good. That's an added bonus. But no, on a kind of serious note, I think that if people understand why they're doing it, why they're taking the antiviral therapy and why it's so important, they're more likely to be engaged. And this is why I think it's so important to kind of hand it to the patients, to give them control, to be at the center of their own management is the key thing, rather than kind of, we're always, talking to the patients, like talking down to them as to what they should be doing. And then, I'm a believer in functional cure. We actively do all the clinical trials. I can see the progress we're making. I don't believe you start somebody on an antiviral now, they're going to be on it in 15 or 20 years. So that probably answers the second part of that question.
Thank you. So the next one is, with the updated guidelines, are there any objective scores that you would recommend to risk stratify patients for HCC surveillance?
Yeah, page B and the reach and mReach, they're probably the main ones. Page B is in there. It's very simple. Gender and age, main drivers. So yeah, it's probably the main one, and yeah, and reach B.
But you said that if anyone over 30 who you're treating, you would survey them. Is that right?
Well, historically, because Vicky, the difficulty there is some guidelines were made at different time points. So these EASL guidelines from 2025, the brand new guidelines, have lowered the bar so much that was the point I was making earlier, that now we're going to be treating so many more people that we will have to revisit surveillance. These studies and people, it's an important point. People always talk about liver cancer and how we detect it and surveillance and all of that. Studies to determine who gets liver cancer and who doesn't are very, very, very difficult to do, as you well know, for ethical reasons, for the time frame it takes to develop liver cancer, etc. So that's why I said earlier, for me, it's always safety first. But we do need, I think, I would certainly be an advocate of using those scoring systems. I also said that the more people on antiviral therapy, earlier on antiviral therapy, the less likely they're going to get liver cancer over the longer term. But we still need to survey them.
Great, thank you. So we've got two last quick questions on the chat, and I think they're pretty similar, really. So one of them is, would you switch from tenofovir to entecavir in young patients who are at risk or who have a history of osteoporosis? And then the second question said, is there anything you focus on while monitoring patients long-term on these medications? So I guess they're asking about the side effects of them and what you tell your patients.
Okay, so just to give the people who are on this call an idea, I probably published the first paper on tenofovir changes in bone mineral density in chronic hepatitis B when Gilead and everybody else was telling me it didn't exist, that it was only seen in HIV. So that's just to give you some context. And then following on from that, I could count on one hand the number of patients I've switched from tenofovir to entecavir for this reason. And then finally, the very last piece, certainly young people, I mean, older people with osteoporosis and stuff is a different ballgame. And then finally, probably worth for people to bear in mind that the next generation tenofovir, which is TAF, will come off patent in a number of years, not that far away. And all those young people who are on tenofovir, then we think they'll be able to access a very cheap drug and a very safe drug in TAF.
Thank you, Patrick. We'll just do one more question, which is kind of interesting question. Is there an acceptable criteria for stopping antivirals in patients who get medication?
Yeah, okay. That's a good question, but it's actually quite a controversial question, so it's maybe not the best question to end. In my practice, do we stop people on antivirals? We don't, because those who are with eagle eyes and following all the data will see it's those patients with very low surface antigen who are very easy to achieve functional cure with these next generation drugs like antisense oligonucleotides. And we know we can predict what happens with those. So my problem with the kind of nuke discontinuation, it's a bit of a kind of throw a stone in the air and see where it lands. So okay. There are emerging data around duration you're on antiviral therapy and very low levels of surface antigen. Obviously, these individuals do much better. And there are thresholds of 100 IU and 1,000 IU, depending on whether you're Caucasian or Asian. But my take home would be always exercise caution here. And there are new drugs going to be in the clinic very soon. And those low surface antigen patients are the patients who are going to do best.
Great. Thank you very much, Patrick. Thank you for an excellent talk. Yes, we will finish the seminar now. But thanks once again.
Okay. See you all. Thanks a lot.
Bye. Take care, everyone. Bye-bye.